Okay. So we, in this first part of the session, we'll limit our questions to the three that we've heard from. So let me turn to the committee. Thank you all for giving us those opening comments, and let's turn to the committee and ask for questions to the folks that you've heard from here. And I'll go ahead while people are sort of putting their thoughts together. If I could go back to Phyllis Greenberg and just ask you, similarly to how we heard from the second presenter about sort of the position, if you will, of your organization, Healthy Women, with the kinds of information that you turn to and provide people on the front end about clinical utility. Do you have a strong position of yes, no, or is it a mixed, here we provide you with the menu of information and suggest you comb through it, and so just sort of how exactly do you respond to people who come your way with questions?
Well, we have on the website, women will send in questions and we answer them. By the way, we do have a scientific advisory board and physicians that we turn to so that we don't, we know that we're giving the best information that's available. We get a lot of questions from women about, anything from, parenting and breastfeeding to colon cancer. I mean, obviously, it's a broad spectrum. We have not, we did revise the information on menopause and hormone therapy recently. As I mentioned, I mean, I don't think we want to go into that whole thing, but there have been changes in terms of disputing some of the findings and updating. And so we've tried to update that to the extent that, that we think is appropriate. And also, as I mentioned, this letter, we had in February, NAMS called together a conference call, and we were on the phone with the FDA for over an hour, or maybe 2 hours, going through all these issues that we've spoken of, and that's when I mentioned to my group at Healthy Women that since we're going to be doing this with WebMD and we're going to be talking about updating menopause and some of the other issues, cardiovascular health, Alzheimer's, colon cancer, that we need to talk about bioidenticals and basically tell the population because as Cindy said, as I said, I've been in women's health for 30 years. I knew that they weren't approved, but I didn't know all the information that I currently know, and I'm sure that most people don't, other than those of us who are involved in it. So I think it's very important. I think in terms of clinical utility, I think it's shown that there is none, or in fact is negative. And I think women have to realize that, and I do take issue with the black box and all these other compounded, but those are issues. I think that it was there ought to be a reexamination in terms of the labeling, which I think would help women feel more comfortable about taking the FDA approach.
Jennifer.
Thank you. I'd like to ask a question to Ms. Hogel. Is she there? I can't see her. So I would like to ask you, presumably the patients that want to come to you for their compounding pharmacy needs need to go through a provider to get those prescriptions. I'm wondering if you could tell us a little bit about who are the providers that you primarily are working with.
Sure. I think, is that to me, Lynn Hography?
Yeah. Sorry. God, I got it
okay.
wrong.
Yeah. My maiden name was Dodge. Gosh, those are the days. When we became a medical facility, we actually have a medical director, and we have two different nurse practitioners who have been immersed in women's health, one of them for over 40 years. She's got 2 doctorate degrees. She's amazing. So with extensive testing, we use dry urine strip testing. And then the women, after the testing, they go visit our nurse practitioner for an hour appointment. She goes over their extensive testing results with them. Then they go ahead and talk about the specific issues. Then she will write a prescription for their compounded BHRT products. And they come back at 3 months to talk about how they're doing for a half-hour appointment, and she can adjust the dosing as she needs to.
Are those visits covered by private insurance ever?
No, they're not. We're pretty much a self-pay operation here.
Can you give us a sense of what it cost and sort of the experience of people as they approach that?
Sure. I can show you. We compound our creams in these little click top dispensers, and it has between 3 and 5 months usage in it. So it's pretty expensive, and it costs $90 for click top for a 3 to 5 month supply. So we feel fairly inexpensive. And what was the other part of your question? I'm sorry.
So, no, that's helpful. Thank you. The other question just related to the response you had that I just wanted to clarify. So you spend time, you come in and you have time with a nurse practitioner for an hour or so, and then the nurse practitioner, you said, writes the prescription
Right.
based
Right.
on that interaction?
Right, and I should preface this by saying that when I began my business model 10 years ago as an educational facility, I'm an educator, a 30-year veteran teacher. We actually spend an hour with every client just sitting here talking, just me and the client or a patient consultant, to make sure we answer their questions, make sure they're comfortable. There's no pressure to proceed with our facility. We just kind of talk about their journey and are helpful if we can be, and those that want to pursue and proceed with us then do so. So they have an hour to get materials, to go to the website, to be given studies and reference materials, books to read, so they're very comfortable. And those that choose to continue on with us then, and they do the testing, meet with a nurse practitioner, the response is overwhelmingly positive. They find that their issues are addressed. They come back at 3 months, for the most part, feeling significantly better. We've got a checklist of the symptoms, and they're rated on a scale of 1 to 10, 10 being a severe symptom and 1 being not so much. And we can actually track then and record their progress over time. They have to come back and see us at least every year, if not more often, for more testing and to check in with us. And the response has been overwhelmingly positive because the therapy is not one size fits most, but customized for each person.
And in the location where you have the encounter with the nurse practitioner, they're allowed to write the prescription. There's no secondary. Is this nurse practitioner working under a physician of any sort, or are they allowed to put the prescription through into the pharmacy independently?
Yeah, we have a collaborating physician. She works underneath our collaborating physician's scope, and she is allowed to write her own prescription, and and then it goes right into our compounding pharmacy.
Jennifer, did you have more questions? Okay.
That pricing, you said $90 for a 3-month supply of, let's say, an estrogen cream?
Right. If you're using it every day, like I do, because I'm really old, it's $90 for 3 months. And if you're using it cyclically 2 weeks of the month, it might last you 5 to 6 months.
Nancy.
Hi, thank you. It's Mrs. Hography, is that correct? Hography?
You got it. I'm giving you a sticker. Thank you. You got it. Perfect.
Okay. Thank you so much for coming. This is really helpful. And I apologize, I should have gone on your website. So I'm going to ask maybe some dumb questions. But I heard you say hormone imbalance a couple times. So are these
Right.
people who have medical endocrine disorders like thyroid? Or, I mean, who are these patients that you are seeing, that you are treating? And what are the symptoms that you're treating? I heard you say estrogen, so it sounds like there might be some menopause symptoms, but are there other, what do you mean by hormone imbalance? Are they across the spectrum? And sorry for my...
Sure, yeah. No, I taught 6th grade. I was teacher of the year. There are no stupid questions. I appreciate your courage in asking whatever. I want you to brace yourself. Are you ready? So we define hormone imbalance as most women who are over the age of 35 who have aging ovaries that don't make enough progesterone become estrogen dominant. So that is a hormone imbalance. Estrogen dominance comes with its own set of issues like weight gain, brain fog, hot flashes, forgetfulness, sometimes energy fatigue issues. So our position is that women even younger than 35, but typically age 35 and beyond, have a hormone imbalance. And if we don't correct those issues at that point, they just exacerbate and become worse and worse, and the symptoms become worse and worse. So, back in the day, 10 years ago when I began my cottage, and nothing against doctors, we love our doctors, we do, but women would often go in for a checkup and they would talk about how they were feeling anxious or depressed or fatigued, and doctors would prescribe Prozac. And our position is, well, you're not Prozac deficient. You're probably hormonally imbalanced with a progesterone deficiency. So it's just a matter of getting everyone on the same page and educating women and showing them their options to feeling better. So does that answer your question? And then we also do treat thyroid with a 10-point blood panel. We also address cortisol issues with our dried urine strip testing. So that's our wheelhouse, is the sex hormones, the cortisol, and the thyroid.
Just as a quick follow-up, how does this, how do you distinguish between PMDD or premenstrual syndrome and, what are you calling this hormonal imbalance? Are you calling it perimenopause? Do you fit that, do you use those models? Do you use the traditional medical terminology of reproductive?
Yeah, we do. Sure, yeah, we do. We can call that perimenopause and of course, menopause and postmenopause, sure.
But not because some of the things you described in a 35-year-old, years ago I studied PMS, and this was very much in the domain of what is now considered premenstrual dysphoric disorder. And at that time, progesterone therapy was considered one option. So I just wondered if that's part of the patient population that you respond to.
Yes. Yes, it is.
Okay, we have some other questions. Jose and then Adele. Thank you.
Yeah, so the question is also for Lynn, and I'm following up on Nancy. So the decision for a patient or an individual to get hormone replacement therapy, you're talking about hormone imbalance. Is it based, so the decision, the recommendation is based on symptoms that the patients describe to you, or there's any diagnosis, blood tests, hormone levels that take place prior to really recommending and moving forward with the decision to begin BHRT?
Yeah, absolutely. Yeah, we do look at the symptoms, and that's part of it. But we do Dutch testing, which is the dried urine strip testing through Precision Analytical, and then they provide a 15-page report on every single patient based on their hormone metabolites. So you get a really good read on their cortisol and their sex hormones and how their body is metabolizing these, so we can really write a great prescription for them based on their symptoms and their 15-page report.
Thank you.
Adele.
Yeah, actually, a similar question regarding the testing that the nurse practitioner does and the follow-up testing. You said hormone levels. Can you specifically say what type of hormones they are measuring?
Sure, estrogen, progesterone, testosterone, and cortisol.
Okay. Any other testing that the nurse practitioner does other than these hormone tests?
Well, we also do the thyroid testing with a 10-point blood panel that also can identify Hashimoto's. We also do genetic testing, which we're excited about, so we can talk about that at great length if you're interested, but this is not the place for that probably. But yeah, we're really about women and men's health and meeting the individual clients' needs the best way we can.
Okay. And the follow-up test by the nurse practitioner, what happens there?
Well, there's a follow-up consultation at 3 months with a half-hour appointment, and the nurse practitioner and the client talk about how they're feeling, what symptoms they're still having, if we can adjust the dosing of the creams. And by the way, we like to use those vaginally. They're vaginal application for the most part. And then at the year mark, we'll retest with another dried urine strip testing from Dutch Test or Precision Analytical. So every year we have the actual 15-page report that we refer to, along with the patient's symptoms. And we use both.
Thank you.
Lee.
I have a couple questions. So my first question is, what kind of questions do the patients come in with? What are their concerns? Do they have questions about, timeline of effectiveness? Just trying to get a sense of what they already know before they come to see you. My other question was, do you ever prescribe or recommend FDA-approved products for certain patients in particular? And then my thought, just with the recent conversation, was what are your thoughts on the effectiveness of salivary tests?
Okay. You asked three in a row. What was the first one? I'm going backwards. What was the first question?
First one was, what kind of
again.
questions do the patients come in with, just in
Oh,
general?
yeah.
What are they asking about?
Yeah.
What are they worried about?
Sure. It's funny, over the last 10 years, it's really been a grassroots movement, and we find that our patients coming in today, for the most part, are very well versed. They've been to my website, they've been to other websites, they've done some reading, so their questions are really quite advanced today. Very, very rarely do I get a client that comes in that has no idea. They're pretty much empowered, especially millennials. They really are empowered. I wrote a book called Own Your Journey. They want to own their journey. So they don't really have that many questions. I mean, they're already pretty well versed. They do want to know about how we test, what's the dried urine strip testing involved, what does it cost, what's the time frame. And we always tell them, the farther away you are from optimal health, the longer it's going to take. So you can pretty much see a gradual improvement beginning at about 3 weeks on therapy. And then when they come in to see our nurse practitioner at 3 months, most women are, for the most part, pretty well balanced. If they're not, there are other issues underlying that we just haven't addressed, and maybe not a hormone issue, for example, or they're on so many other medications that they don't know they feel better, perhaps. So that's the answer to the first question. Give me the second one again.
Do you recommend FDA-approved products to certain patients?
That's a great question.
Rarely, but
yeah,
occasionally.
yeah, sometimes we do. We do it. We can and we do. We're really just about, individualized therapy and trying to customize and adjust the dosing for the client. So we really prefer to compound in our compounding lab, but sometimes we do. And then salivary, I remember the third one, aren't you excited? Salivary testing. Back in the day, we did saliva testing with Dr. David Zaba, ZRT, amazing man, great lab. But we found some issues with women who were already on therapy and the validity of the results. There tend to be some contamination of the results. So when Mark Newman, an analytical chemist, created the dried urine strip testing, we really came on board with that cutting edge testing. We like it better than collecting urine because, number one, it's messy. Who wants to really collect urine? And the dried urine does a really great job with the cortisol piece. So that's the kind of testing that we use today. We've just moved on from saliva. We feel like the dried urine is a more advanced, more cutting edge, more informative, and more reliable type of test.
Okay, Rula.
Yeah, so we've heard a lot today about the range of kind of things that you can get for bioidentical hormones, including, oral versus pellets versus creams, and whether they contain estrogens or progesterone or testosterone. So I was wondering if you could provide sort of what the range of products are provided, and also maybe some, I don't know if you have frequencies, or what are the most commonly used or prescribed at your cottage?
Okay, yeah, so we create a really nice, it's called Biest, bi meaning two. So our estrogen product, our cream, is Biest. It's Biestrogen. It's 60% estriol and 40% estradiol. And so it's a nice combination of the estrogens. And then we use a great progesterone. We separate these out. Then we have a progesterone cream that we love. Then we have testosterone cream as well. We often put in with the estrogen. So it's a Biest/testosterone combination. We also have, of course, we can compound thyroid medications as well. We also have, for adrenal issues and adrenal fatigue issues, a great proprietary blend of an adaptogenic herb product that we use for adrenal fatigue. And then we can make adjustments to dosing based on the women's needs, based on their testing and their symptoms. So we can actually go from, let's say, 4 clicks on the clicky top to 3 clicks or 5 clicks, and then we can customize. I've been on my CBHRT for 14 years, so I'm pretty sold on what it is that we do, because I know that it does work for most.
Susan.
So also to Ms. Hography, have any women come back and express concern about any adverse events that they may have had? Do you, and if so, do you modify their dose or modify the treatment in any way? And do you keep track of these concerns?
Yeah, absolutely. We do have a patient portal, Power to Practice, that we use and keep really, really great notes. Every so often we'll have a woman who has some breast tenderness, maybe, I I don't know, that's probably the biggest complaint that I've heard of. And sometimes we have to lower the dosage. We like to listen to our body's symptoms to understand what's going on, and we can adjust dosing to deal with that. So if there's a little bit of breast tenderness, we normally dial down on the estrogen. If they're still having issues with sleep, depression, anxiety, mood, we can increase the progesterone. That's the beauty of separating the products out using a vaginal application. We don't use pellets at our facility. We just want to use physiological dosing for each woman. We find that to be the most safe and effective. And there's more information on that on my website as to why we don't prefer pellets here. But yeah, so I think, did that answer your question?
Yes, but let me just follow up. If a woman came in and said she chronically had breast tenderness, would you recommend against using any of these products?
No, we just lower the dosage. And then we check back within 3 or 4 days, and it's normally typically gone. I mean, that's, again, the beauty of customized hormone therapy is that you can adjust the dosing easily, and within a matter of a day or two, the symptom has been rectified.
Robert?
Yeah, this is a question for Ms. Hogarty. In your educational process, do you find that women coming in for an initial consult or follow-up visit make reference to the black box warnings in product labeling for estrogen products or progesterone products, and that kind of complicates the message about their safety and efficacy?
No, we don't have that issue. Every client does sign a client consent form, and it talks a little bit about what it is we do, and so they're signing off on that. So, and they've done their research, they've done their homework, so we don't really find that to be an issue.
Could you tell me a little bit more about that client consent form? So like I've come in, with whatever and been introduced, and then I'm going to have my 1-hour visit. So what does that form look like? Is that on the website too? Can I look at it? I'm just to get a sense of it.
Yeah, I think it is. If you go to my website, which is happyhormonecottage.com, and you go to the Begin Your Journey, I believe it is there. It is on there. It talks about bioidentical estrogen being a part of what the body makes, and it mimics what the body can no longer make enough of. So we compound that. I can also read it to you if you want. It talks about estriol, protective estrogen, thought to reduce risk of breast cancer or recurrence. It's a much safer form of estrogen because it isn't metabolized into other hormones, giving its unique identity. So we talk a little bit about that. And we also encourage them to get their GYN checkups and their thermograms or mammograms and their physicals every year as well.
So let's see. Robert, you're done. Okay, sorry. Nancy, I'm coming. Jennifer and then Nancy. Thank you.
Sure, you just addressed my question right there, which is, are your patients, in your experience, telling their other providers about their hormone use? Do you know about that? And what kind of care are you providing versus what kind of care a general practitioner would provide for them? Are they still going to their general practitioners?
Yeah, that's a really great question. Yeah, the answer is yes. Back in the day when I began, again, 10 years ago, this is more relatively, I would say, newer. And so a lot of doctors hadn't heard about the customized BHRT. And so we got a whole gamut of feedback from, oh my gosh, it's witchcraft, you can't do that, to let's give it a try and see what happens. And so over the last 10 years, as women have gone back to their OBGYNs or their practitioners for feedback on how they're feeling, it's been overwhelmingly positive. So now these doctors are sending their clients to us for hormone therapy because we're specialists, it's what we do. And they really can't do that in a 15-minute insurance-based appointment. It's just too much. So we've had a lot of collaboration with some really great doctors here, including psychologists, psychiatrists, all types of doctors. So it's been very positive, a great growth over the last 10 years. And then they do go back to their OBGYNs for checkups and pap smears and feedback, and we get a lot of partnership from that.
Just one other follow-up. So we know how much the drug is. Can you tell me how much your hour-long appointment costs?
So the nurse practitioner, it's $200, and then the half hour is $100.
Thank you.
And we do provide CPT codes so they can get reimbursed with their insurance if they're able to.
That's what I was wondering.
And then the testing, how much is that?
Yeah, the testing is $350. And again, we provide CPT codes so they can get reimbursed. We also take HSA cards and flex spending cards. So a lot of our clients are able to use their own HSA or flex spending cards to cover the cost of that testing.
And how often do they have to do that testing?
Every 12 months.
And maybe you mentioned it and I forgot it, but how many different people come your way through your services? And how long do most of them end up following up with you?
I'm not sure if I understand your question. We've treated thousands of women over 10 years. And we did a study a while back. Over 85% of our women stayed with us. Some of them discontinued because they move out of the area, or their husband loses a job and they can't afford anything for themselves. But it was 85% or higher retention rate, which we're pretty happy with.
And by thousands, you mean 5, 10,000, 20? I mean, like over just a ballpark.
Gosh, I'm not looking at my husband here.
Active now, I think we should get them.
I would say
I'd say we have
15,000,
that's probably more.
20,000. It's hard to say. I mean, a lot. A lot. 15,000, a lot.
Thank you. Okay, Nancy, I think you had and I think this will be our last part of this, and we're gonna turn to the other one, and then hang on if you don't mind. Don't leave us, because we're gonna hear from the second part of this, and then perhaps there'll be some questions that go across. So thank you all so much. Nancy.
Yes, again, for Mrs. Hography, I want to make sure I understand who is your patient population. And I think I heard you say basically anybody who's 35 or older would be considered having a hormonal imbalance. I heard you also talk about adrenal fatigue, and the adrenals, clearly the hormone levels start to decline, certainly in the 30s, in both men and women. So is there anybody that you would not potentially want, that you would screen out for this kind of therapy, who came to you with symptoms, for example? And I'm thinking of breast cancer patients, or patients at high risk, or endometrial. I'm encouraged to hear that you are working with other practitioners, and do you follow them with mammograms, or is that a requirement in your practice, or is that part of the consent form? And do they first have to have an endometrial biopsy, or can you just give us some of your safety guidelines that you use?
Sure. That's a long question.
I know, I'm sorry.
Yeah, we do have them sign a paperwork that says they will get their pap smear, and they will get their, honestly, we prefer thermograms here, thermography, but mammograms are fine, whatever they can do to help, protect their breast health, and they can prove that they have great, health is what we require. But if you're any kind of a cancer survivor, breast cancer survivor, cervical cancer, we have now started doing genetic testing. We really prefer to get, genetic testing done first. It talks about methylation for safety and efficacy. We have a really great conversation. We really screen that population. The clients that come to us, honestly, are the ones that have a higher education and they have disposable income. If you're struggling to make ends meet and feeding a family, you're not going to take care of yourself and come to us, and you shouldn't. But if you have a higher education and you have the disposable income and you're interested in taking care of your health, and you can with what we do, then that's our population. Does that help?
So thank you all so much. Let's move now to the second panel. Nancy's actually going to take the lead here in moderating that. So hang on, we'll probably come back with some other questions that go across. Thank you.